Sue is a physician with many years' experience working in rural, urban and mine and conflict settings, and has worked on a wide variety of medical and social issues. She's currently working at the World Council of Churches as their healthcare representative, and is also interim coordinator for the Ecumenical Advocacy Alliance's HIV initiative. Sue.
Thank you very much, and I would like to applaud the organizers for their vision in pulling together a conference of this nature. And I'm also very grateful for the privilege of sharing some very rich data from our faith-based responders in the most Ebola-affected countries. But I would particularly like to acknowledge our faith health providers in those countries who were the frontliners on the front line and who paid the ultimate sacrifice in their service. In my presentation today, I'm going to divide it into two parts, just looking at the contribution of the religious leaders to the epidemic and the contribution of the Christian health providers. We have not much data on the Islamic health providers, and there is a gap in the research there. I'm not going to talk to all the slides, but they're up online, but I'm going to flip through them so you can see what's there. Of particular note is hot off the press research that was just came out just a couple of days ago, and which a study was done looking at the role of the faith leaders in addressing the Ebola epidemic, particularly in relation to social mobilization, stigma, physical assistance, and psychosocial support. What's really interesting about this research, and I won't go through it all, and I do recommend you look at it online because it's very good, and it was widespread consultation. But it demonstrated that the initial outbreak, the faith leaders played an essential role in organizing the communities to prevent and control the Ebola outbreak. And the other thing that was of particular note was the wonderful collaboration on the interfaith level. Now, our religious leaders, they use the existing platforms, the interreligious councils, the interfaith health task force, the malaria and immunization networks, the HIV networks, the church pulpits and mosques, and they even had pulpit swaps. They used every platform that was already there to raise awareness and address stigma. They used every kind of feast or festival that was taking place, whether Christmas, Easter, Ramadan, to promote these positive messages. But crucially, they also engaged with the chiefs and the local community leaders to help them understand about Ebola and communicate the importance of the safe and dignified burial practices. And by getting them on board, it gave them access into villages, and some of these villages were very remote, whereby they could get in there where people would have been very hostile to foreigners coming in there. Under the KAP Study 3 in December 14, 47% of respondents quoted that the churches or the mosques were their source of information on the Ebola virus-related messages. The other things they did, they distributed sanitation equipment, material support for quarantined people, and a real walk the talk in destigmatizing Ebola survivors. In terms of the lessons learned, it demonstrated that the faith leaders played this essential role in the social mobilization and behavior change. But what brought about the change? Well, it was basically what the faith leaders stood for. It was their values. They were motivated with a spirit of compassion, and they used the biblical and Quranic verses. They had unprecedented access to communities, and they were trusted. They had a long history of being with the people, and they were trusted. And they also advocated on behalf of people for assistance. In terms of the scale, Sally has already alluded to it. Guinea and Sierra Leone and Liberia, the numbers were massive. When we come to what the UNMIA response was, they had two phases. The first phase was a technical stop the epidemic, and their second phase, where they're moving towards a zero, was where we had to engage with communities. Well, our faith-based leaders were there with the communities right from the very start. And 71% of the referrals to community care centres were made by social mobilisers, the community leaders or the religious leaders. Now, our faith-based organizations and their leaders, they have this historical, continuous presence through war and peace. They don't talk about exit strategies. And their accompaniment of people through significant events in their lives and their voice on behalf of people has earned them the trust and respect of the communities. They quickly saw the importance of volunteers, and I will come to that a bit further when we talk about the church health associations. Now, the church health associations are the medical arm of the church. They're non-partisan in their service delivery. They're the bedrock of rural health care, and they contribute to a substantial portion of the national health care, particularly in the hard-to-reach regions where they are underserved and where the poor are usually found. They complement government provision, but yet they're very often not involved in the decision-making fora. And this was amply demonstrated in Sierra Leone, where the very first case of Ebola was identified from. There was in the region of 3 Christian health facilities, but not one of them was notified of the risk in their area. What they chose to do when Ebola struck was they made a deliberate decision not to deal with the Ebola cases. They didn't have the skills or the training or the facilities. Instead, they took a two-pronged focus. One was to keep their facilities open. Facilities were closed all around in Sierra Leone. The government even told the facilities to shut. But they chose to keep them open and to keep safe and keep serving. And that was to ensure that the other essential services continued to be provided. And what they had to do was then restore confidence in their health workers and in the communities by providing training and protective equipment and distribution of essential drugs to reopen facilities that have been closed. But all that they had to find themselves. Government did not provide any of that to them. And they provided extensive training. On the community side, they realized that they could not wait for patients to come into the hospitals. That would take too long. Sometimes it took 12 hours for an ambulance to bring in one patient. So they said, we have to get out into the communities and find the patient. And they were told this is too dangerous. They said, we have to, because these people are in the communities and they will go to the homes of the nurses who are out there. And so they trained people who then trained general community health volunteers, who then each had 40 households to visit. And there they identified dead people. They assisted with the safe and dignified burial processes linking with them. The people who were ill, if they felt it was a risk, they immediately isolated them in the homes and helped them with rehydration while they arranged for referral. And then they helped the communities understand what they were dealing with. And these 4,000 odd volunteers, they visited over 160,000 households for 21 to 90 days. They visited each of these. So this is just a snapshot of, they're everywhere. On the far side, these Christian health facilities, they're right there in the communities. That's Sierra Leone, widely scattered throughout. In terms of the safe and dignified burial guidelines, the faith community worked with the UN agencies and International Red Cross to change it from dead body management to safe and dignified burial. And all credit goes to World Vision and CAFOD and CRS, who took over half the burial practices, procedures in Sierra Leone. And since November, these 57 teams have given a dignified burial to over 16,000 people and maintained the cemeteries and ensured that each grave was marked. And that way, it improved the acceptability amongst the people. In terms of the World Council of Churches, what we tried to do was promote a collaborative response between all the stakeholders, from the UN level through the theologians down to the Christian health associations, the councils of churches. And we did that at global level, regional level, and national level. Here we have a person living with HIV with the Church Health Association person. This is just a snapshot of the various countries that we engaged with to firewall against Ebola and as a preparedness against future epidemics. And finally, Ebola is a classic example that where you have a disease which requires essentially a behavior change, a technical response alone is insufficient. Community engagement is absolutely essential, but the communities need to be engaged not as helpless beneficiaries in need of our technical expertise, but as people with resilience and capacities and local knowledge and a vested interest in survival. So some of the biggest challenge, sorry, have I gone backwards? Sorry, this is the last thing. Okay. One of the biggest challenges the UN agencies and other agencies have is the preconception and prejudices that associates the faith-based humanitarian service with proselytization. However, the faith-based services complement government, and their service is because of their mandate of their faith and an expression of their faith. But there's an underappreciation within the UN system of the extent of their presence, their capacities, their local knowledge, and their sociocultural understanding, and their linkages with the communities. So everybody was late to the table with Ebola, and particularly, unfortunately, our UN agencies. And when they arrived, they didn't leverage the capacity of the people who were already on the ground, and the faith-based and the NGOs who had already been working there. And that was a pity. So in terms of recommendations, early engagement of faith-based Christian, Islamic, traditional healers and societies is really critical. They have the local knowledge and the community influence. Our faith-based health service providers, they need to be recognized, supported, and included in policy planning, implementation, and budget allocation. There's an urgent need to collaborate to develop an inventory or analysis of the facilities and the services provided and their capacities, geographical coverage. We need to improve the communication channels for information flow and decentralize our disaster risk management and include the faith-based people in the chain. They have huge networks, and create these opportunities for interface between our UN agencies and our faith-based organizations and our governments. Collaborate with respect, and if the bottom line is the dollar, it is cost-effective to invest in the faith-based community engagement. Thank you very much.
Thank you, Sue.